I'd like to acknowledge the traditional owners of all the lands upon which we're joining this press conference this afternoon. I'm here in Redfern, so it's the Gadigal people of the Eora Nation, and pay respects to elders past, present and emerging. We have two speakers this afternoon, Dr. Karina Powers and Professor David Anderson. So first we'll go to Karina, who will give us a bit of an update on the current state of play with COVID-19. Karina.
Hi, it's Dr. Karina Powers. Please share my slides. Okay, there have been over 1,073,095 cases reported in the community since September 2021. 49.3% of all cases are below 30 years of age between December 2021 and January 2022. Over 95% of those are over 16 and fully vaccinated. 75% of those are between the ages of 12 and 15 and are fully vaccinated. In the past 2 weeks, in the past 4 weeks in New South Wales alone, there have been around 240 deaths. This is similar to a 737 Boeing crashing every fortnight. You can also see listed there hospitalizations and ICU. And the thing about the ICU listing is it's not the reflection of the full story of what's happening in our hospitals, that some critical cases may not be having access to ICU, and also some very sick patients are elsewhere on wards, on other technologies other than ventilators, trying to stay alive. Next slide, thank you. And we can see here modelled, thank you to Professor Nunes-Vaz, we can see actual cases, hospitalizations, and also the modelling. And the problem is we've got no idea of the real number of cases out in the community. The data is confounded by an enormous amount of underreporting. There is likely a gap in the model because under 65s were encouraged not to go to hospital. So it's making it very difficult to understand what is really going on out in the community. So next slide, thank you. We are aware that Victoria started from a higher caseload base, and this was, they already had some disease out in the community, probably Delta. And again, we can see a gap between actual and that modelled. And again, we just don't have a real handle on what the real prevalence of the disease is out in the community. People aren't able to access PCR testing easily at all, and there aren't enough RAT tests available. Next slide, thank you. And we can see South Australia likely has a better accuracy for the cases because their testing systems haven't crashed so far as in the other states, and there is a better fit for actual and the modelled hospital occupancy. Next slide, thank you. In the ACT, likely the very high level of vaccination being protective for the amount, for the percentage actually being admitted to hospital. Thank you.
Thank you, Karina. Our next speaker is Professor David Anderson. Over to you, David.
Thanks very much, Michael. Could I have my slides, please? If the next slide, please. I'll talk about why we think it's really urgent that the governments at federal and state level work together to resource rapid antigen tests freely available for everyone. It really is essential with the breakdown of PCR testing capacity that we have RATs as an alternative. Several months ago, the appropriate use of RATs in high burden settings, workplaces such as fly in, fly out, etc., was really very useful, but its use in the community was not terribly useful while we had plenty of PCR. But now that we don't have plenty of PCR capacity, really we have to rely on rats to get that diagnostic capacity back. But in order for that to really work, we need to have better educational material, including in languages other than English, and addressing the fact that there are many different rat tests out there which have different swabbing techniques, different procedures to run the tests. And this is not a trivial exercise. Unfortunately, unlike PCR, which is always done by professional people in labs, we're expecting people to run these tests at home. And we can't expect the data to be good if the information is not prepared properly. Could I have the next slide, please? The other real problem we have with rats currently, and perhaps even more so if they become more readily available, is that we don't necessarily get the data on who has had a positive test. We certainly don't get the data currently on who has had a negative test, so that we don't get a measure of the percent positivity, which has been very important in tracking the pandemic. We do still get that from the substantial number of PCR tests that are still being done, but optimally it would be really good if we could get it for the rats as well. And preferably this would be via the QR code systems that people have become so familiar with over the past year or so of the pandemic. We haven't been able to maintain the capacity for case surveillance and contact tracing, but once this surge has passed, that doesn't mean that we should give up on that as a goal for the future, because it really is the way that we can hopefully contain future outbreaks of new variants, which we expect will come along. And while many of us would prefer that the rats were simply mailed out to each household, as they are in the UK, for example, if rats are going to be through central distribution, such as pharmacies, and many of the big pharmacy chains have indicated that they would be more than willing to provide that service, even if the tests are being provided for free. If that's not the case, then we need people to be able to access that information centrally, because the last thing we want is potentially infectious people going around the shops looking for rat tests and exposing other people while they don't know one way or the other whether they're infected. If I could have the next slide, please. There are a large number of rats approved in Australia by the TGA. There's 22 currently, and there are a number of others in the pipeline. And for all of these tests, we have information provided in most cases by the manufacturer, but scrutinised by TGA, on the sensitivity and specificity that provides validation of these tests. And in the next slide, we'll talk about some of those where that data is more readily available. And people need to have a little bit of understanding of what sensitivity and specificity means. Sensitivity for any diagnostic test, but including for a rat, means how well does the test perform if you have the disease in detecting that you do have the disease, and in this case, detecting the viral proteins that indicate that you have COVID-19. If the test is highly sensitive, it means that if you get a negative test result, most likely it's because the virus isn't present. Although it must be noted that in the case of these tests, and especially for home use, that depends on the swab or the sample being taken properly and the test being performed correctly. And so there will sometimes be a difference between the reported sensitivity where it's been done by professionals or under supervised conditions versus the actual observed sensitivity when it's performed by people at home. But if we put it simply, if you have high sensitivity, then if you do the test correctly and you're negative, then it's very likely that you don't have the infection. Specificity, on the other hand, relates to what the chances are of getting a false positive result. That is, you don't have the disease, in this case COVID-19, but the test comes up positive. And this is a common feature of rapid antigen tests. It took us 20 years to make HIV antibody tests that don't give any real number of false positives. We haven't had that luxury with the antigen tests, and especially since swab samples from the nose, from the throat, from saliva are much less consistent than blood samples that are used for things like HIV and hepatitis C, where rats are extremely specific. And the issue with specificity is that if 1 or 2 or 5% of false positives are happening, then rats are not very suitable if the level of community transmission is too low. And just a few months ago, I was one of the people advocating that we should not be switching our reliance from PCR to rat tests, because there would have been too high a proportion of false positives. More than 50% could have been false positives. But now that we have such high levels of community transmission, the low false positive rate of somewhere between 1 and 5% for most tests is not going to stop the tests being useful. And they're combined with high sensitivity, they are going to give us an idea of how much transmission there is that would otherwise be missed, because PCR simply cannot keep up with demand. If I could have the next slide, please. This graph shows the sensitivity in blue and the specificity in red of about 15, the first 15 tests that have been approved by the TGA. It is important to note that the y-axis on this graph is truncated. It only shows from 75 to 100% to highlight the differences between these tests. And you can see that all of the tests have good specificity, between about 98 and 100%. And that means, you know, if it's 98%, that means 2 out of 100 people will get a false positive result. And that's not a good thing. But in the current setting, that is better than none of those 100 people being diagnosed one way or the other. The sensitivity is quite a bit lower. And for some of the tests, it's significantly lower, down around the 80 to 85% mark. And that means that even if the test is performed properly, there will be a significant proportion of people who will get the wrong result. And that's why we often advocate, and many people are doing this in practice, that you don't rely on a single antigen test done a single time, that you might run the same test with new cartridges on subsequent days for a few days running. And that's when the sensitivity really improves to very, very high levels. But you know, a lot of the work that I do at the Burnet Institute is focused on developing these kinds of tests for the developing world. And in the developing world, where you don't have access to good laboratory diagnostic systems, we typically think that anything that can give you above 80% sensitivity is really good. It is very unfortunate that with the high levels of community transmission at the moment, we no longer have in Australia, despite very well-established pathology systems, we cannot keep up with the demand for PCR. And so we're in the same boat of having to accept less than perfect tests as being a lot better than nothing. Thank you.
Thank you, David and Karina. Do we have any questions from anybody attending the press conference? If not, I might ask you a question, David, and that's about the confusion caused from the changing advice around, and you said yourself, you were recommending PCRs. What can be done to help clear up some of that confusion? I think it's really not clear to the community, and what could the media and government do to try and make it quite clear why this is where we're at?
Yeah, I think as part of the education system and the information system about how to use the rapid antigen tests, that can all be built in. But I think that we don't have, there's not a lot of negativity about the rat tests. I'd have to say my message didn't really get through last year. So in many ways, it's good that much of my negativity and other people's negativity about rats never really created that much of a barrier to the uptake of rats. And we always felt that they were useful in many settings. And so I think if rats were readily available and with good information, people would want to use them. And this is part of why we've issued the new advice in the face of the Omicron wave that refines that message for the setting of high community transmission.
They're not exactly, David, easy to understand how to do the tests. And I've had people ask me, some of the Koori mob, about how do you actually do it? Where can people get information, and how can the media and government help with it being clear how to actually do the test?
That's one of the reasons that I think it would be really useful for the government to be controlling the free and ready supply of the tests, is that they could then choose the most appropriate tests. Of the 22 tests that are available, it's not really practical that we would have detailed instructions and video or pictorial instructions for all 22 tests available at the same time. Some of the tests will be more suitable for use in community, for example, and more readily adapted to those kinds of instructions. And the government could then choose which are the more suitable tests. It shouldn't be left up to the open market, because then it will come down to who has the best advertising, who gets their supply into the most places. We really should be doing, as the UK did, where they made a massive investment in just a few tests, and they worked with the manufacturers with plenty of advance notice to make sure that that information was properly available. Because I would hate to see people using one brand today and a different brand tomorrow, because that's the surest way to perform the tests incorrectly.
I've done that myself, done 3 different types of rat tests, and each one has been slightly different, and it does feel quite confusing.
Yeah.
The next question is for Karina. Karina, what are the implications of not having accurate data about caseload and testing for policy, health service, community, and political understanding?
When we don't have accurate case data, we just cannot properly help our hospitals get on top of things. We don't understand which variant is coming into the community, and really we're relying on hospitalisation data being very accurate to have some sort of idea about when peak is. It's not helpful to not have full case data, because you cannot plan adequately for how you're going to resource addressing the system, not only in the short term, but also in the long term for long COVID cases as well. Already, I hear in Canada, even they're setting up long COVID clinics in areas that have just starting to have spread, because the caseload's becoming quite clear they're going to need that. And obviously we have plenty of long COVID clinics in the UK. I mean, this is really going to be a significant drain on our health services for the future. And if we could only do correct and adequate testing and tracing and suppression of a disease, we can really help our future load in the health system.
Can you just explain a bit? I think everybody is assuming, people are doing rat tests assuming they have Omicron, but they may well have Delta. And that these have serious implications about the different variants.
Yes, so Delta appears to be more severe, but Omicron is still a severe disease. Delta has a bigger implication for the ventilator need. Omicron has a bigger indication for load in those hospital wards, which might be one step off ventilation, such as oxygen provision, which could really suck up oxygen supplies. And we have to be very careful that we're not going to lose our oxygen supplies, that we've got adequate supplies for the need in the hospitals, let alone the ability to staff the hospitals adequately and have enough beds for people. So it's really quite a serious situation when we've got no handle on the true number of cases. And we are hearing stories in the East about people not being able to access hospital services either for COVID itself, and they've got lower saturations of oxygen, or for their diseases that are other than COVID. And the other comment to make is there's been this issue about being admitted for some other disease other than COVID, but a lot of those can actually be precipitated by COVID. They might not have been the first thing written on the form for why someone was admitted, but COVID could still be the main cause of why they were admitted. So for instance, if you have a high fever and you're dehydrated, you're more likely to fall over and break a bone or have a heart attack. But they may say, oh, they were admitted for a heart attack or they were admitted for a broken bone. It wasn't due to COVID. We tested for it later in the ward and that's what popped up, but that wasn't the main cause of the admission. What I am saying is, yes, COVID could well be the main cause of the admission. And really to be able to adequately plan for these things, it would be very good if they reinstitute very good testing, tracing and monitoring to understand what that caseload is. And otherwise, we're just looking through the rear vision mirror of how our hospital data changed compared to previous years, which didn't have COVID.
Did we have any other questions or any questions from people attending the press conference? If not, we may go to David first, if you want to give us some final words about what you think we need to do. I guess I'll preface this in a little way that there seems to be a bit of a view that it's Omicron, it's not too bad.
Yeah.
It is bad. Like it's still, you don't want to get Omicron. So
it's really, really bad. And it's only, I think, even though cases may, with a bit of luck, be peaking, we don't know when they may come down. The high transmissibility of Omicron means that it may not have the same sort of rapid decline that we've seen with Delta and previous waves. And even with the current case numbers, the current mortality numbers, it should be remembered, reflect the number of infections we had roughly a month ago. And a month ago, we didn't have anywhere near the number of infections we have today. And even though Omicron is slightly, and I would say only slightly, perhaps 50% as pathogenic as Delta, Delta was twice as pathogenic as the original strain that came, that was isolated in Wuhan. And so we're looking at a virus that's pretty much what we had in March 2020, and that killed a lot of people. Now, we have vaccines and other things, but it is not a mild virus, and particularly not for the unvaccinated. And so with still significant numbers of people unvaccinated and such high levels of transmission, we can't shield effectively the vulnerable people who are left. And if someone thinks, oh, I don't want to be vaccinated, but I'll just be careful, well, good luck with that, because with Omicron, it's like measles. You can't be that careful that you can have a realistic expectation that you can avoid it forever. I don't think it's inevitable that we will all get Omicron. I think that we can be careful, we can wear good quality masks. Karina will probably talk about vaccines plus, and I'll ask her to expand on that. But it is very hard to say that everyone can avoid getting Omicron, because clearly over 1 million people who are not being too rash about things have already got it in just over a couple of months.
Thank you, David. Karina, and you've gotten a bit of a cue there as well. Vaccines plus, they are still incredibly important.
Yes, so vaccines plus includes everything from vaccines to safe indoor air ventilation and good quality masks, which for Omicron, we recommend respirator type masks. These are N95, P2, KF94, that people really need to use constantly in any indoor air zone, and seriously consider using them in outdoor air zones as well, where there's crowded spaces or you're getting close to people. You really need to keep a very good distance between you and others with Omicron, and make sure that your high-level mask has a snug fit. It cuts a lot of the risk, but it will not take away all the risk, and people should carefully look at how they're behaving, because you need to remember this wave will go away. Eventually it will settle down, but in the meantime, it would be very tragic to have the disease yourself. We know it affects so many organs in the body, in the brain, and I've seen recent research that shows how it shrinks structures in the brain. It's a terrible disease to contract, even in a mild to moderate level of symptomatology. It's best to be avoided, and to do that, we need to look at our safe indoor air, wear our masks, limit our exposures, and for just what's necessary, and try and do things like work from home where it's practical. So all these advice can be found on www.OzSAGE.org on the web. There's advice for how to improve your home situation and make it safer, so there's less risk of transmission at home as well. So I recommend everyone have a look at that.
Thanks, Karina. Of course, the paper you've both spoken about this afternoon, Living with COVID-19 Requires Governments to Resource Rapid Antigen Tests, is also available on the website, or will be very shortly. It is actually a quick read. It's about 3 pages and it's incredibly informative. So I'd recommend anybody who wants to know more about what's occurring and what can be better to have a read of that. This press conference will also be available shortly on the OzSAGE website. So I would like to thank both our presenters this afternoon, Professor David Anderson and Dr. Karina Powers, for their presentation. And that's it for us. Thank you.